young people in the juvenile justice system are at considerably higher risk for health, mental health, and substance abuse problems than are youth not involved in the justice system. These range from vaccine-preventable diseases all the way up to suicides. For example, while the overall risk of death for juveniles housed in residential facilities is only slightly higher than the national average for juveniles, the risk of death from illness is 30% higher, and the risk of death from suicide is almost tripled. The risks of death from homicide and accidents are lower. Health, mental health, and substance abuse are but one part of the spectrum of ills for this population that range from recidivism and education failure to discrete psychophysiological diagnoses. The relationship between crime and health, mental health, and substance abuse is clearly complex. I think Dr. Kinner in his graphs identified the complexity of that relationship. However, there's a strong research-supported and legal basis that suggests tending to these needs is not only required at some level that is still yet to be determined, but is sound public and social policy. As such, this presentation will address current service provision to identify opportunities and gaps. It must first be noted that there is tremendous variation among juvenile justice residential facilities as to health and mental health care services provided. This is partially a result of state-by-state policies, but is also a product of the variation of the different types of facilities that house juveniles, from short-term detention centers to shelters to reception and diagnostic facilities to boot camps to ranches to group and halfway homes to residential treatment centers and to long-term secure facilities that are similar to prisons. Each unique type of facility could have the youth for different amounts of time, which would limit the access to care in some of the shorter stay facilities. Yet these shorter stay facilities are most often the facilities that the youth enters into in the beginning of their stays in residential facilities and where assessment is most urgent. As a result, some of the facilities in the later stages rely on earlier facilities to conduct screenings and assessment, which is not an assumption that is often valid. An additional explanation for the variation in services is the lack of national standards and guidelines to regulate treatment. And those standards or guidelines that do exist are not evidence-based. Many are simply best guesses by well-meaning clinicians, but they're still not evidence-based. Our research reveals that facilities don't follow these few standards and guidelines when they exist anyway. For example, the American Academy of Pediatrics has recommended that juvenile residential facilities follow the standards of the National Commission on Correctional Health Care, yet less than 2% of facilities have been voluntarily accredited to these standards. One basic standard is the screening of juveniles when they enter the facility. 2% of facilities offer no health screening at all, and 15% offer no suicide screening at all. Well over half of those that do screen used an untrained screener, and less than 15% use some form of a trained health screener. And as the care provided for juveniles at these facilities is often their only exposure to medical treatment, total health screening and treatment would be ideal. However, very few facilities screen all incoming juveniles for issues such as vision, dental, or if girls, gynecological needs. These are issues that can become more costly and risky as the juvenile ages. Early diagnosis and treatment is more than just humane, it's cost effective. One disturbing trend that our research reveals for multiple health and mental health conditions is the reliance on the juvenile to request services in order for them to be provided. This runs the gamut from girls having to ask to be tested for STDs and pregnancy upon admission to suicide screening. This is bad policy because evidence clearly shows that requiring these services, with or without the youth's request, is preferable. For example, screening every youth within the first 24 hours of admission significantly reduces serious suicide attempts and suicides. Evidence-based policies to reduce suicide risks and to identify other healthcare issues should include screening all juveniles within the first 24 hours of intake by trained screening professionals. Time and again, we find that systematic approaches are beneficial, while ad hoc ones are not. Those facilities that provide more health and mental health care, including but not limited to testing for communicable diseases, providing vaccinations, having immediate first aid treatment available, providing recreational exercise opportunities, and assessing suicide risks and other mental health issues, are most often larger facilities. With each one-person increase in facility population size, the odds of providing high service levels increase by 1%. Related to this, the facilities that provide more care are also more likely to be government-owned and operated as opposed to privately owned and operated. Similarly, the longer the facility houses the young people, the more likely it is that higher levels of healthcare services are provided, which is counterintuitive because most of these kids go to the shorter stay facilities with a rapid turnover. Compared with those elsewhere in the country, facilities in both New England and the West are more than 2 times as likely to be at the top tier of service levels. Also, facilities housing higher percentages of African American young people were significantly more likely to report higher service provisions. Involvement in juvenile justice residential facilities provides a unique opportunity to provide health and mental health care maintenance for adolescents who most likely does not have a medical home. The time that these young, medically underserved, high-risk youth, high risk in terms of medical future, not offending in this case, spend in these facilities represents perhaps the best opportunity for healthcare workers to intervene. Accordingly, providing quality evidence to guide policies about this ever-increasing priority is imperative. Policies based on anything else besides evidence will be beneficial only coincidentally, most often will not help, and possibly could be detrimental to the health and mental health status of the involved youth. These youth will almost all return to the community. Addressing their health and mental health issues while under the care and supervision of the juvenile justice system will save both future treatment costs and risk to the public health. Again, as we are here to promote evidence-based research, I have synthesized 6 evidence-based research articles summarizing OJJDP censuses of juvenile residential facilities. If you want to discuss that, I can email the articles to you. I can discuss after the meeting. Thank you very much.